we'll also end by discussing, potential, members' ideas for agenda items for 2025. So, think about potential topics to bring up for the end of this meeting. So we'll also start by thanking some of the members that are coming off the SAC this year, right, Amelia? Okay, great. And those are the starred names here. Yeah.
Yep, that's right.
So we have Diana Lynn, who was my co-chair, is exiting. Matthew Celentano, Benjamin Fulgencio Turner, Emily Hodson, Sophie Keene, Scott London, Marie-Therese Oyalawo, and Aaron Phillips are all have served their time in the committee, and we're very grateful for their contributions. So I just wanted to say thank you for their time. Great. So we'll vote on last meeting minutes. So I move to approve the Standing Advisory Committee meeting minutes from September 12th, 2024. Does anyone second?
Second.
Great. Hearing that seconded, does anyone have any objections? Great. Hearing no objections, the meeting minutes are approved for the September meeting. Thanks. Great. Well, we'll start out with Aika giving us an update on the Board of Trustees activities. So I'll hand it over to Aika for the update. Thanks.
Thanks, Mark. Can you all hear me okay? Perfect. Thank you. We have, since our last September meeting, you all haven't missed too much. We haven't had many meetings in between, but some of the updates that has come up is Scott Brennan presented a bit on the compliance and privacy annual report. And so we talked a bit about some of the primary topics that we're looking at MHBE policy updates and revision initiatives, the annual fraud, waste, and abuse report, and the privacy program metrics and audits. Nicole came and talked a bit about the approved medical and dental plans for the plan year for 2025 and noted that WellPoint is entering the individual market stateside for the first time. And it's now one of the 4 carriers offering plans stateside in addition to CareFirst, Aetna, and United. And Kaiser continues to be available to offer plans in select counties. And then Brad came from MIA and explained a bit about just MIA's roles and some of the things that you're doing to ensure that the rates are not excessive, inadequate, and unfairly discriminatory. And then lastly, we approved, trying to remember, brain. We approved an AWS contract subscription for not to exceed, it's about a year for the FY 2025 period. And then lastly, Becca came and we talked about an overview of the draft value plan designs for the plan year 2026 that the value plan work group is voted on unanimously to recommend. So, and we discussed. I think that covers everything. Happy to turn it back to you, Mark. Does anyone have any questions by chance?
Okay, great. Thank you again. Okay, so we'll move on next to the executive update from Michelle. Michelle, I think you're muted, Michelle. Thanks.
You'd think we would know this by now, right? Thank you. And thanks everyone for joining today. And thank you, Mark. I want to start by just echoing my thanks to those Standing Advisory Committee members that are terming at the end of this year, to Scott, Matt, Emily, Sophie, Marie-Therese, Ben, Diana, and Aaron, thank you, thank you, thank you. We really rely on the work that you do and your expertise and the insights that you bring to the committee. And it helps our Board of Trustees understand what's going on in the community, gives them expertise and guidance. And certainly for the staff, really allows us to run ideas throughout the community and get feedback and just make better policy decisions and better operational decisions with your guidance and input. So thank you very much. We will miss you. We know that there is still opportunities to be involved with the exchange. And of course, I'll put my plug in again, like I did last time. We do have 2 board members rolling off at the end of May. And there will they will be green bag appointments, which are done in February. So if anyone is interested in serving on the Board of Trustees and meets the qualifications, please go to the governor's appointments website and file an application, get your recommendation letters in. If you're interested, it helps to have a recommendation letter from a legislator. I will tell you that as well. But please, we welcome having you in any capacity, whether it's on another work group or on the board or just continuing to feed information into our ears. Very helpful. So thank you. So a few updates from the executive office. This is our first meeting since the election, and we're kind of focused on what may be coming down the pike for us next year. Some of the immediate impacts that we envision, of course, under President Biden, the definition for DACA recipients were made lawfully present citizens. And so we have actually 47 that have enrolled in health coverage for the month of December already. And we have 70 that are signed up for January. We don't know what will happen, if this will be revoked. And what our message is right now is that this is the rule of the land, and we will be providing health coverage until we learn different. So that's obviously a low-hanging fruit that is of utmost concern. The other low-hanging fruit that is of utmost concern is the expanded tax credits, which are set to expire December of 2025. And we know that that has afforded many more Marylanders the opportunity to have affordable health coverage, whether they were over the 400 percentile of FPL, whether they were in the lower income brackets. We're hopeful that that would be continued. I think we're less hopeful now that that will be continued, but we're not going to stop advocating. And we ask all of you to continue advocating with your federal delegates that this really has provided immense amounts of coverage for Marylanders. Another sort of low-hanging fruit, we have our 1332 waiver in with CMS waiting for final approval. And of course, as you may recall, this will allow all Maryland residents, regardless of documentation status, to be able to purchase at full cost health plans through the exchange. So we'll see what happens with that. We're hopeful that that will continue to move forward. But again, everything's kind of up in the air at this moment. And then thinking about what the impact on the state's reinsurance program will be. Of course, if we lose those expanded tax credits, we know that that will affect the amount of pass-through funds that will be coming in for the reinsurance program. Right now, that program will continue through 2028, calendar year 2028. So again, we'll see what happens with that. The impact on health insurance rates. Again, all of this will play into the impact on health insurance rates. If we end up losing younger, healthier consumers because of the fact that they perceive they can't afford their health coverage, that will impact the risk pool, which will impact rates overall. Potential changes to the small group market. We will watch that. There were, under the last Trump administration, there were plans put in place to expand short-term limited duration health plans, association health plans, employer professional organizations, things like that, that are out there. We as a state have put a lot of things, codified a lot of things in our state rules to prevent that. But again, not certain what kinds of health plans will be made available, if they're temporary, if they're lower coverage. So we'll be keeping an eye on that. Any of the protections that are afforded under Section 1557 of the ACA, we'll see if there's any rollback of that. And again, we still know that's out there is preventive coverage measures. So we'll see what happens with that. And let me see, we're just keeping a list of all things and trying to plan for them. Abortion coverage mandates. So you might recall under the last Trump administration, there was an effort to make sure that when we billed for premiums, we had to segregate out the amount that was allocated for abortion services to cover abortion services. And there's a lot of confusion around that. There was a court case to address that. So we'll be monitoring that. But again, right now, what we are doing is an exchange with other entities across the state. And of course, we welcome anything that comes from your purview to put on our radar, but we're really trying to be mindful of what might come down the pike that would dismantle any of the efforts that we have achieved to get our exceptional high growth rate in coverage. So I'll stop there. And again, welcome anything from the SAC. If you've got any other insights, please share it with us. In terms of open enrollment, and I'll answer questions at the very end if that's okay. In terms of state updates, we are right in the midst of open enrollment right now, going great. As of yesterday, we had over 211,000 consumers enrolled. That's 18% more than this time last year. But remember, we have the influx from the public health emergency unwinding. So we're really happy about that. And then also just as a state agency, we are looking forward to how we can contain costs for the state. And as a state, knowing that as the state of Maryland will be entering into some financial challenges as we move forward. So we're very mindful of that as we look to how we proceed into 2025. Let's see, for our things going on at our agency, of course, we have just such wonderful, dedicated staff that make everything move beautifully. And one of the things we had this week was a press conference with Vinnie DeMarco, who's one of our greatest cheerleaders, and we were able to talk about the Young Adult Subsidy Program continuing beyond 2025 out of a pilot program. So as long as there's funding available from the existing funding we have to continue that program, again, it's been hugely successful. We've had a ton of open enrollment media coverage, so our team's out there and really getting the word out. And one of the new things, and you can find it, we can probably put the link up. I'll add the link before we end, but there's something new that our marketing team did this year, and it's called Man on the Street. And it's a person that we've hired to go out to festivals and anytime there's farmers markets and things to really talk to people, say, tell us what you know about health coverage. And it's really fun and informative. And it's just another way to, again, raise the bar for how we're getting people informed and getting them ready to enroll in health coverage. So I will stop there. I know there's a couple questions and I'm happy to try and answer them. And let's see. I see whose hands were up here. I think I saw some hands. Oh, okay. Scott London, I saw.
Hi, Michelle. Thanks again for the opportunity to serve on this board. It's been very rewarding. You and your team are amazing, and the work that you do is so meaningful to our community and our states. I want to start by saying that I'm grateful and grateful for you. So thank you. Reading the tea leaves of the crystal ball, how do you think the Trump administration is going to handle exchanges as they relate specifically to Medicaid and even drilling down on that to the undocumented residents of our state?
I really have no idea. I was on a call earlier today and I asked some of my Medicaid colleagues if they've looked at anything, what they're hearing, and they don't have anything yet either. So I think it's all too new, and I think we're all doing the same thing of like, okay, what do we have to make sure the protections we've already put in place, or what we might need to put in place, or what simply will no longer be. So I think we're all evaluating that now.
Maybe I'm sort of hearing the same thing, which is not a lot in that very specific area, which maybe that's a good thing. Fingers crossed.
Yeah. And I see Stephanie has put in some press coverage for the young adult subsidy. Thank you, Stephanie, for that. And Maggie put that YouTube video up that I just love. And what do you know about health insurance? It's really fun. So it's in the chat. And I think, Stephanie, you had your hand up.
Yeah, thanks, Michelle. Well, first of all, thank you for your participation in the press conference. It was really great, and we really got a tremendous amount of press coverage, and we'll be fighting hard to continue the young adult subsidy next session with Maryland Healthcare for All. And just great news about DACA recipients already enrolling in coverage and the great numbers of open enrollment so far. I had two questions. One is if we've heard anything from CMS about potentially expediting their review of the 1332 waiver amendment application, and second, if SAC is seeking new members, and if so, what the process is to encourage people to apply.
So to answer your first question, we already have reached out to CMS just to make sure everything was on track. Everything's on track, so we're just waiting for their final decision on that. And the one thing that we did do, we did make the decision as the exchange to not advertise as much as we had planned to advertise about DACA, and that's just merely for the fact that we're nervous about getting people coverage and then having to terminate that coverage. So that's it. But we will certainly continue to work with all of our connector entities and our stakeholders to let people know. And CASA has been a great partner. So we know the population of DACA recipients in this state. And CASA, I think there's 7,500 of them, and CASA has actively worked with 3,500 of them. So, we have a really good partner in CASA to make everyone aware of coverage.
Thank you. And I know we have some great members from SAC rolling off of the committee. Is SAC seeking new members to the SAC committee? And if so, is the application open for that?
I think Amelia might be able to jump in, or Johanna. I think the application process starts in January, but I might be wrong on that. So Johanna or Amelia, if you want to address that.
Yeah, we will be recruiting new members, and the application usually goes live end of December, beginning of January. So we'll get started soon, and we'll send out notices to the current SAC members, and any input you have on new recruitees, we always welcome.
Thank you.
Thank you all. Back
Yvette,
to you.
I noticed that you raised your hand as well during the
Sorry.
sales update. Did you still want to ask a question? Maybe it.
Who was that, Mark? Who raised their hand?
I think Yvette had raised her hand at one point. I noticed during the update.
No, it was a mistake.
Oh, okay. Okay, no problem.
I was trying to give a thumbs up.
All right. Thanks. Back to you, Mark.
Thank you so much for the update. It's good to hear about all the things you're thinking about. I'm sure there's a lot to prepare for. Okay, so we'll move next to Maggie Church, Deputy Director of Marketing for MHBE, who will be giving an update on the open enrollment readiness. Thanks.
Hi, thank you. Yeah, you can jump to the next slide.
Actually, you can keep going to the next one. So last year, as Michelle mentioned, was our most enrollees ever, and we made some great gains with 64% increase in new enrollees. So this year, we're really focusing on those target audiences that we usually put emphasis on, but also what our MHC plans offer in order to attract eligible uninsured Marylanders and retain our existing ones. Next slide. So in addition to TV and radio ads in English and Spanish, we're going to run ads to engage our African American and Latino audiences and drive enrollment through print and newspaper ads. We've also printed advertisements on the back of dollar store receipts. We did this last year too, and we found it worked well. Next slide. We're going to run digital ad placements, video placements on YouTube, and digital audio placements across podcasts and music. We do display ads, and new this year, we're going to run ads on dating platforms like the Match.com group and Reddit. We've already had a couple people get on Reddit and make comments about. We turned off the comments on our advertising on Reddit ads, but we've seen that some people have been using Reddit to crowdsource answers for questions about how to enroll or something else with their plans. We're also doing micro influencers this year, and those are social media influencers that are local to Maryland. This week, a bunch of their content is going to be going up on their channels, and then we repost those videos, and also we put money behind them just to boost the range and the reach. Okay, next slide, please. And then new this year, we're running ads in church bulletins across the state in November and December. We're also doing billboards outside of Amazon warehouses. And then in addition to events across the state this open enrollment season, we hosted a webinar in October that was to brief all of our partners what's new this year and how to engage their communities. We've had a focus on DACA for that one. CASA was one of our guests and talked about the new laws and eligibility surrounding DACA. Next slide, please. Here's an example of our print ad in newspapers, and then also the one on the left is the ad in the church bulletins. Next slide. Open enrollment provides us with a lot of opportunities to capture digital stories at events, and we use those stories on our YouTube page and all of our social media sites just to have people meet real Marylanders who have enrolled through Maryland Health Connection or Maryland Health Connection for Small Business. And this year we also partnered with NAMI, the National Alliance on Mental Illness. And we had a webinar for consumers right before open enrollment started about mental health. And we just want to make sure that Marylanders know that all of our plans include mental health, mental and behavioral health services. We had great turnout for that. And then we posted the webinar on YouTube afterwards and have had a lot of people watch it at a later date. So that was exciting. And then this last slide is the timing for our paid advertising. A lot of our television and display and search advertising really started after the election advertising, just for cost saving purposes. Can I answer any questions? Okay, well, thanks for having me. Oh, Joanne?
Yeah, it may be a bit early to know this yet, but I'm just curious. I mean, with the first Trump administration, they did a lot to cancel ads, and this was on the FFE end. Cancel ads that were scheduled and paid for, and pull back on navigator funding. And I'm just wondering if you saw any spillover for your exchange that has sort of muddled the message, especially with or if you're thinking about if you have to do something different, if there's a broader message for the federally run marketplaces trying to tamp down.
Yeah, that's an interesting question. I'm not sure what the federal, the FFM plans to do. I do know that we put a lot of, each year we do a lot of focus on our search terms and just SEO, search engine optimization, to make sure that when people do Google us or use Bing, they can find us pretty easily. And so there'll always be a couple of paid ads above us, but I think that, most of our search terms, I mean, we have thousands of them from, every word combination you can think of with health, Maryland, health insurance. And so far it's doing pretty well. But again, it's early and they haven't started yet. But we find that it's our display ads for Google and our search terms do really well. People find us really easily. So
Okay.
I remember you guys presenting that we do get a lot of transfers from healthcare.gov. Is that something that I feel like I had heard marketing share that in the past, but I might be misremembering that? Or if that's something we're able to track.
Yeah, we can see that in our Google Analytics. You can see how many people, like where people come from. Do they come from an organic search, or do they come from like one of our emails? Like, how are they actually arriving at our website? And so at the end of open enrollment, we usually do have a number of how many people arrive from going to healthcare.gov and then clicking Maryland. I don't remember off the top of my head what that number was last year, sorry, but we do usually do a wrap up of that after open enrollment.
And I will just add to that, the good thing being a state-based marketplace is that we're not affected by any funds that are eliminated for navigators because we fund our own program. So we're insulated from that.
Yeah.
Okay. Well, thanks for having me. It was nice to share our media plan with you.
Okay, thanks so much, Maggie. Okay, we'll move on to Amelia, who will be presenting on the Consumer Decision Support Workgroup and the report of their recommendations.
Thanks, Mark. Again, Amelia here from the policy team at the Exchange. I'm just going to give a quick update on the MHBE Consumer Decision Support Workgroup and their final report of recommendations. And I had given an overview of this work group earlier to the SAC at the May meeting, so I'll just summarize again really quickly the purpose for convening this work group. So MHBE organized this work group specifically to address consumer decision support during the plan shopping process in order to further address challenges that we know are still present for a lot of consumers when they're shopping for health plans on the Exchange. And we know it's important for consumers to not only enroll in health coverage, but also to choose a plan that best fits their needs, has a benefit structure that actually provides the level of coverage that they need for their health conditions, and then that also maximizes financial assistance that's available to them. So the ultimate purpose of the work group was to discuss areas to improve consumer decision support during the plan shopping experience when they're using our Maryland Health Connection Get an Estimate plan shopping tool, which is our anonymous browsing tool where consumers can input their eligibility information, check for financial assistance, and then view and compare plans that are available to them. And ultimately, the purpose of the work group was to develop a set of recommendations for improved or more effective decision-making support when they're plan shopping, in order to better choose plans that fit their health and financial conditions. And the work group discussions, just because it's such a broad scope of considerations, we kept the discussions focused specifically on private plan shopping and just in the individual market. So in terms of work group outcomes, the work group just convened their last meeting yesterday, actually. So they met 7 times starting this summer, between July and November of this year. In addition to all the discussions, we also included presentations from research partners from other state exchanges on best practices in how they provide consumer decision support. And then we also heard from a lot of MHBE staff on what we've learned from all the consumer user experience testing that we've done in the last couple of years. All of this being presented for the work group's consideration in their discussions. And ultimately, the work group compiled a series of recommendations in kind of three main focus areas. So the first one, just generally identifying areas in the plan shopping experience where consumers may benefit from more information or guidance in order to better promote health literacy and just generally improve confidence in plan shopping and plan selection. A second bucket was improving how we display plan information on the actual plan shopping page, as well as the side-by-side plan comparison layout to make sure that we're presenting the right amount of information to consumers, but also that it's not overwhelming and they're best able to make an informed decision about their plan. And then the last bucket was targeted specifically considering how the MHBE could consider implementing tailored plan recommendations to consumers based on consumer inputs and what they provide in the anonymous browsing tool. So the full report was just finalized yesterday by the work group, and it will be available on the work group page on our MHBE partner site. So if you follow that link, I'll send out these slides again, but you'll be able to see the full report soon if interested, and I can also share with the work group after this. I'll just go over some highlights from their full set of recommendations that they provided, just to give an idea of what was discussed and what was recommended by the work group. So one kind of major recommendation was to overall simplify the plan tile display. So I put in an example of what an example of one plan and how it's displayed on our plan shopping page. There's a lot of information, and the general consensus from the work group was that the overall amount of information that's currently displayed is probably overwhelming for the average consumer, and the layout is structured in a way that may be a little confusing to read. So the general recommendation was to reduce the amount of information that we display on each plan tile for plans on that plan shopping page, and make, if you can see, I'm not sure if you can see my marker, but there's a details button on the bottom right corner of the plan tile. So the recommendation was to make that much more prominent to drive consumers to that, because the details button includes a much more comprehensive amount of information about each plan and all the cost sharing for each covered service, et cetera. So just generally reducing the amount of information we display and navigating consumers more towards buttons that would give more information on each plan. Another recommendation that was generally agreed upon by the work group was to simplify the explanation that we give regarding financial assistance. So when consumers input their income, they're given an estimate for financial assistance that they may be eligible for. And the work group provided feedback that the explanations of estimated financial assistance, particularly the premium tax credit, was maybe too technical and should probably use more consumer friendly and plain language. So for example, instead of saying premium tax credit, maybe we could say premium assistance. Instead of saying cost sharing reductions, we could say help with lowering out of pocket costs. Some more plain language like that, that's less policy wonky. And then a final highlight, the work group discussed and agreed that it would be in the consumer benefit for MHBE to consider providing options to give consumers a few tailored plan recommendations that are listed first in the plan shopping page. And we used the example from Washington State and their health benefit exchange. They have their consumer plan shopping tool that works very similarly to Maryland Health Connections. They call it Smart Plan Finder. And it also includes the functionality of being able to provide tailored plan recommendations to consumers. So the tool collects consumer information based on questions that are asked the consumer before they get to the plan shopping page. And then the tool weighs that information. It calculates net premium costs based on subsidies available. Includes in the calculation any preferred provider network or pharmacy coverage that the consumer input into the tool. when it's scoring a plan to ultimately generate a tailored plan recommendation to consumers. So the work group generally agreed that MHBE could consider an approach that's similar to Washington's. I think that's it for my overview. Again, the full report will be on our website in a couple weeks, so you're welcome to read through the full report of recommendations, but I'm happy to answer any questions if there are any for now.
Thanks so much, Amelia. I had a quick question. Would the I was curious about like the smart choice. Like, are consumers able to like put in, you know, as detailed as like my primary care provider is this or something, and does that factor in, or is it like, are they able to, or were you saying they just list their preference for like you know, an HMO versus a PPO? What?
Good question. Yeah, they so Maryland Health Connection has a provider directory as well, and you can look up specific providers, and our tool will show each plan and whether or not that provider is covered by that plan. And so Washington has the same thing, the same provider directory that a lot of states do. Right. They gave a more detailed breakdown of the scoring and calculations for a plan, and they do factor in the provider directory if a consumer said, I specifically want this provider covered. So to your question, yes, they score it based on if a consumer puts in that information, they will show whether that provider is covered and then weigh that in their ultimate
in the smart choice. Okay, cool.
Yeah, yeah. Joanne?
Yeah, thank you. I'm looking forward to reading the report. Just a couple questions. Can you, does this steer, will the smart choice steer them towards the silver level plan for maximum PTC? It's one question.
Do you want me to answer that question?
Yeah.
First?
Yes.
So I'm sure I'll actually, in one of the work group presentations, we had Washington come in and give an overview of how their smart choice plan recommendations were set up. And so they have kind of the hierarchy of how the plans are scored, and then, you know, how they gear them towards silver cost sharing reduction plans if someone's eligible for that. They also have standardized plans. So they have a whole hierarchy of kind of how they structure their list of plan recommendations, and then how they structure the kind of auto sorting after those plan recommendations. So I'll send out their presentation and it would give you more information on that.
Okay, well, my second question is related. I was wondering if shoppers can sort on the value plans or otherwise easily find them with some sort of clear indicator. Is that already available, or did that come up in these discussions?
Yeah, that is already available. So we highlight if a plan is a value plan, it has kind of a flag and is clearly marked as a value plan. And then you can also sort just to see value plans and shop specifically for them. Yeah.
Thank you.
Thanks. Well, if there's no further questions, thanks for letting me join and present on this, and I'll hand it back to Mark.
Awesome. Thank you so much, Amelia. I think next up is Johanna to talk about the Young Adult Subsidy Program. And then I think the next item after that will also be led by Johanna. So if you want to just keep going, that works too.
Sounds good. So yes, happy to update you on 2 reports that we're doing that kind of touch on different aspects of the Young Adult Subsidy Program, which we'll be submitting over the next month or so to the legislature. So wanted to share some preliminary results from those, since we're not going to meet once we submit those until May. So wanted to give you guys some little heads up on what we're seeing in our evaluation. Invite your discussion of that. And you heard from Stephanie and Michelle already about the legislation that's being proposed to extend the Young Adult Subsidy Program, but we'll touch on that as well. Next slide. So as you guys are probably well aware from our previous conversations, we launched this program in 2022, initially as a 2-year pilot. And the program uses state funds to further reduce young adults' premiums. So it's a reduction on top of the federal APTC premium subsidies that they get. And the two function together to make coverage lowest cost for the youngest and lowest income young adults, and then kind of slides up as you get older and higher up the income scale. It's funded with $20 million currently out of our state reinsurance funds, although last year we thought and were given legislation that allows us to roll over unspent funds from prior years because we underspent the first 2 years of the program. And so we had some money that was sort of, mentally allocated to the program that hadn't gone to it that we are now able to use this year and in future years. So I mentioned it was initially a 2-year program. It was extended for an additional 2 years. I definitely took away from this that a 2-year pilot is too short a pilot for the state, because by the time, it's ended, you don't really even have data from the first year to assess how well it did. So 4 years is a much better pilot period. I'm very glad we were able to get that initial extension. And now I feel like we have even though it's still, really just a few years of full data, we've got some data to do a proper analysis of the impact of the program. So we can move on to the next slide. So just a quick refresher on the parameters for the young adult subsidy. Individuals have to be within or equal to 400% of the federal poverty level and ineligible for Medicaid, and enrolling on exchange. For the first 2 years of the program, eligibility was from 18 to 34 years old. We expanded that up to 37 years old for the second 2 years of the program, because we had seen in those first 2 years that we were not getting the enrollment we had anticipated. And thus we were underspending, as I previously mentioned, the $20 million that we were allocated for each year. We realized once a Medicaid redetermination started with the end of the public health emergency that those first 2 years were very impacted by individuals not moving out of Medicaid, because once those redeterminations started, we saw a huge growth in our young adult enrollment. And so we were happy that this program was in place to help kind of make that coverage more affordable as people were moving off of Medicaid into private coverage, and also kind of brought into focus the impact that Medicaid had been having on our young adult enrollment, with folks being able to stay in Medicaid during COVID. You can see at the bottom here, I won't go into details, but the sliding scale that I mentioned. So now with eligibility up to age 37, individuals through 18 to 33 are eligible for the largest amount of young adult subsidy. And then their eligibility phases out from age 34 to 37. We didn't want to have a sharp cliff where you're sort of getting max, and then you become 1 year older and you get nothing. So we have a phase out implemented in as people age out of the subsidy. Next slide. So just kind of snapshot on what we've seen in the program, and this is data through basically, roughly as of the end of open enrollment each year. So as of the end of January. So the program launched in 2022. So you can see in the left-hand column, we started out with about 32,000 young adults, and that number was pretty much the same as of year 2 of the program and as of the end of January 2023. And then mid-2023, we launched Medicaid redeterminations and saw individuals moving out of Medicaid and into private plans. And then you can see the impact by January 31st, 2024, when we were actually still in the middle of our 12-month process of unwinding individuals out of Medicaid. Our young adult subsidized enrollment had jumped up to nearly 53,000. And then as of that same point at the end of January this year, we had about 21,000 individuals who are not receiving the subsidy, and that would be because they were over income above that 400% threshold, or they chose not to provide their income when they are enrolled, which we presume indicates they know they're above, they're not likely to get subsidy, although it could be because they don't want to get advanced tax credits and they'd rather reconcile and get them when they file their taxes. So we can't say for sure why they're not doing that upfront. The average dollar value of the young adult subsidy has been pretty consistent, upper $30 since we launched. But you can see with our big enrollment growth in 2024 that our estimated annual spend jumped. And that's where that additional spending authority to roll over those unspent funds from the first 2 years comes into play for us. Next slide. So to get to the evaluations that I mentioned, we have 2 connected reports to the legislature that we're submitting at the end of this year. The first relates to a particular provision in the young adult subsidy program that was implemented by or passed through legislation after the program launched in 2022. So we, subsequent to our initial launch, got this legislation that directed us to use the young adult subsidy to cover the portion of premium that's attributed to benefits that are not considered essential health benefits. So there's a lot kind of in that statement. I'll provide some quick background on what I'm saying there. So as y'all may be familiar, the Affordable Care Act designates a set of services considered essential health benefits. And there's kind of 10 broad buckets of services like hospitalization, prescription drugs. And then within those buckets, each state selects what's called a benchmark plan, and that plan then delineates what specific services are considered essential health benefits, more or less. But there are a few benefits that the Affordable Care Act explicitly says cannot be considered essential health benefits, and that includes abortion, adult dental, and adult vision. And federal premium subsidies cannot be used to cover the cost of non-essential health benefits. So if I'm an individual who's receiving federal subsidies and I enroll in a plan that includes abortion coverage, which all plans in Maryland do, and may optionally, some also include adult dental and or adult vision. The portion of the premium that the issuer determines is applicable to those benefits cannot be covered by my premium subsidy from the federal government. When we initially launched the young adult subsidy, we used the same terms basically as the federal premium subsidy. And so we were also not covering the non-essential health benefit cost with our young adult subsidy dollars, partly because it was a little bit easier to just get that up and running really quickly if we just mimicked the federal structure. And we didn't have a lot of time to get this program launched once the legislation passed. Thanks to the American Rescue Plan Act and the enhanced federal subsidies that brought about, we had essentially a new group of lower income people who now got enough federal subsidy that they qualified for a plan at no cost to themselves. Their federal subsidy covered the full cost of the plan. But we still had this kind of issue of we have these non-essential health benefits that weren't being covered. So technically they could, be eligible for a $0 plan based on their federal subsidization, but because we had these non-EHBs in the plan, they were still on the hook for $1 to maybe $10 per person per month, depending on what essential health benefits were in their plan. And there's a bunch of literature that shows having these nominal premiums can be a deterrent to enrolling in coverage, that having to make that initial premium payment is, some people just don't get over the hurdle of administratively getting that premium paid, or they're more likely to lose coverage during the year because they miss the payment and end up losing coverage due to that. So kind of that's all the background. So starting in 2023, pursuant to legislation, we started using our young adult subsidy dollars to cover this non-essential health benefit portion of premiums. So people who would be young adults who would be eligible for a free plan could truly get a free plan. We would cover that last dollar or last few dollars with the young adult subsidy. And pursuant to this legislation, we were directed to study essentially the impact of this program and the possibility of expanding it to individuals of all ages. So that's kind of part one of what we were looking at over the last year. And then part two is just a much more general, broad evaluation of the young adult subsidy to give the legislature an analysis of how that program is doing as they contemplate whether to extend it during this upcoming legislative session. So that's the background. Next slide. So I'll start off with our evaluation of the last dollar coverage. And, long story short, we did find that it significantly improved enrollment uptake and retention for eligible young adults. We have kind of, in summary, we estimate that in 2025, based on the experience we've seen and analysis of the first few years of this being in effect, that we will get about 1,700 young adults effectuating their coverage who would not otherwise have effectuated coverage. So if they had to pay their non-EHB portion of premium, they just never would have, and they wouldn't have gotten into coverage. And then we anticipate that about 800 young adults who would have lost coverage at some point during the year will actually remain in coverage because of this policy. If we expanded this subsidy, this last dollar subsidy, to all ages in 2025, which as far as I know, there's no legislation proposed to do so, but just we were using that as a year to make these estimates. We anticipate that 1,400 individuals aren't young adults. So in addition to the 1,700 young adults would effectuate their coverage, meaning they would get kind of actively into coverage who otherwise wouldn't. And about 1,000 individuals who would have dropped out of coverage during the year would remain on coverage. So certainly, meaningful numbers when we look at our total marketplace enrollment of roughly 215 and 220,000. In each of these groups, young adults, we're talking about more than 1% of individuals who initiated or maintained coverage. And if we expanded the program, we'd be looking at more than another 1% of enrollment who would initiate or maintain coverage. On the right, you can see the historical data that drove these projections. So on the top table, this is changes in effectuation rates, and effectuation is the people who enroll in coverage and pay their first month's premium. Of course, for folks who have no premium, they don't actually have to pay that premium. Once they enroll, they are effectuated. So you can see that, and these numbers are it's a little peculiar because 2023 saw the Medicaid redeterminations launch, which had suppressed our effectuation rates, because as these folks in Medicaid were moving into QHP, they may have been determined eligible for QHP, and maybe started the enrollment process, but didn't ultimately effectuate. And that could be for a variety of reasons. They actually really should have stayed in Medicaid. We saw, people move back into Medicaid. They were on employer coverage and maybe started down this path, but then they're like, no, I don't need this. So it was kind of an odd year to be looking at this and doing a comparison, but you can see that we experienced a drop in effectuation for everyone, essentially, except the young adults getting the last dollar coverage. And when we look at just the beginning of 2023, prior to the Medicaid redeterminations happening, and compare that to the same months in 2022, we saw that young adults eligible for last dollar coverage did effectuate at nearly 100%, which is what we would expect since they don't have to actually do anything to effectuate. So kind of removing the Medicaid redetermination time period, we see nearly 100% effectuation for those young adults. Then in the lower table, we're comparing lapse rates. Lapse is the number of people who dropped coverage during the year. And we have our three cohorts: non-young adults, young adults who are ineligible for the last dollar coverage, and then young adults eligible, and their ineligibility would be due to being above the income limit to be eligible. And so we see that the lapse rates are basically the same year to year from 2022 to 2023, except for those eligible for last dollar coverage when it dropped almost in half. So those young adults who are getting that additional subsidy are much likelier to remain in coverage and not lapse, which was to me a particularly exciting finding to see that magnitude of impact. And I see we had a question from Allison. Are non-young adults in the tables those enrollees who would otherwise pay $0 but have a small premium responsibility due to the non-EHB portion? So no, the non-young adults it's the entire population. We didn't split out the non-young adults between those who could have been income eligible for last dollar for a $0 plan. We just looked at, we segmented everyone who's not a young adult and then just young adults who are either eligible or ineligible for the last stage. But that would be an additional, an interesting additional step to take the analysis in, Allison. Yeah, Mark.
Yeah, I like. I guess I like the implication of Allison's question. I think that might be a nice comparison to think about non-young adults who otherwise were income eligible for expanded subsidies. Did you look at all at not just coverage, but what people are enrolled in? Did it change anything along the margin of upgrading to silver plans as opposed to bronze or anything like that?
That's a great question. We did not delve into that, but I think that would be a good future research question. Joanne.
Can you say again that what are the non-EHB? I think I heard adult dental. Is that right?
Adult dental, adult vision, and abortion coverage.
Thank you.
And not all of our plans include adult dental or adult vision, but they do all include abortion. So everyone has at least, roughly $1 of non-EHB that they have to pay. All right, next slide, Amelia. And so then this is just some summary analysis for the broader impact of the Young Adult Subsidy Program. So just kind of data snapshot, we've got nearly 60,000 young adults currently receiving the Young Adult Subsidy. So we're switching gears here, not talking about those just getting that last dollar coverage, but basically any young adult at or below 400% of the federal poverty level is eligible for the general Young Adult Subsidy. So nearly 600,000 young adults getting the subsidy, and it reduces their premium by about 30%. So they're getting an average of $38, and that knocks their average premium down from about $125 per month to about $87 per month. So we thought with our partners at MIA and our contracted actuaries through many iterations of how can we assess the impact of this subsidy, because there was so much going on during the period that it launched. So it launched in 2022. We saw COVID impacting enrollment. We saw the federal subsidies increase substantially during this period. So and then we saw Medicaid redetermination start. So how do we look at what may be attributable to this subsidy versus those many other kind of big shockwaves in the healthcare system? And the approach that we landed on was to identify a cohort of states that were similar to Maryland in that they were Medicaid expansion states, and they did not implement an 1115 waiver during the time period we were looking at. So there wasn't a major structural shift like a reinsurance program affecting affordability in their states. That gave us a cohort of 28 states who fit those criteria. And then we looked at the the legally present uninsured rates estimated for that cohort of states for young adults compared to Maryland. So we took uninsured, and of the uninsured, we looked at how many young adults are uninsured, and then specifically how many legally present young adults are uninsured, because that's the cohort that's eligible for the subsidy, eligible to enroll on exchange. And because different states have different rates of undocumented populations, if you include those in the uninsured rates, it kind of gets everything kind of messy. So stripped those out, just legally present uninsured young adult rates. How did those vary? And we compared, I think 2019 and 2022 rates. So we were trying to look pre-pandemic, kind of pre all of these different shocks to the system. And then 2022 was the most recent census data that we had available at the time to check uninsured rates. And based on comparing those two cohorts, we estimate that there was an overall 5% decrease in the number of uninsured young adults in Maryland, which we're attributing to the young adult subsidy. And that equates to about 4,700 young adults. Now, there could be other factors at play that differentiate our uninsured rate from this cohort of states, but you know, there's only so many variables one can figure out to look at in an analysis. So based on that, you know, that analysis, that's the change we saw in uninsured rates. So definitely happy to see that our young adult uninsured rate compared favorably to that national cohort. And then just overall, since the start of the young adult subsidy program, our young adult enrollment is up 46% compared to our all age enrollment has increased about 30%. So again, you know, there's a lot of different factors playing into who's moving into private coverage, but you know, that is huge growth in our young adult enrollment, and it does exceed our all age enrollment growth. And then, you know, one important lens to look at our young adult subsidy, and that our affordability work group that way back when recommended we consider this subsidy, is that of health equity. Black and Hispanic young adults are disproportionately likely to be uninsured in Maryland and nationally, and we saw significant increase in those groups of young adults. Just looking year over year from 2023 to 2024, we saw Black young adult enrollment increase by 46% and Hispanic by 50%. So we've got a lot more detail will be in the legislative report, and Amelia will definitely share out these two reports when they are finalized and shared with the legislature, so she'll send those out to you all. So again, as others on the call mentioned, we anticipate legislation in 2025 to enable the continuation of the young adult subsidy program beyond its current sunset at the end of 2025. And we are going to be thinking through, you know, we're going to be watching with bated breath what happens with the enhanced subsidies. And for example, the $0 coverage, it doesn't really work if we don't have those enhanced subsidies, because there's not going to be many, if any, individuals who have a fully subsidized plan without the enhanced federal subsidies. So, you know, the thought experiment or possibility of expanding that program to all ages may be a moot point if the enhanced federal subsidies go away. But with that, welcome any thoughts or questions from our members. Yeah, Joanne.
Yeah. So the enhanced PTCs. Did you say that the report is going to be the final report in May, or what is the timing on this?
Both of these final reports should be out by mid-December.
Mid-December. Okay. Do you think you'll also be able to take it sounds like you will raise the potential impact of loss of enhanced premium tax credits. in the report, perhaps, just what might that mean for enrollment and opportunities. But the other thing I'm wondering is, Michelle mentioned that to the extent some of this is funded by the pass-through funding, that would also be reduced if enhanced PTCs go away. It's like almost like a double hit. A, you lose the $0 premiums that make possible enrollment for many people, and then you might lose some of the funding at which you've been able to use unspent funds and grow the program. So I'm wondering if you think you'll be able to address all of that in this report, because it seems to all have an impact on enrollment and what you can do to grow it, right? The parameters of the program.
Yeah. So the zero, we definitely plan to state like the $0 program doesn't really make sense absent the enhanced federal subsidies. The impact on reinsurance, that's a great point. That's one that we addressed globally in the House Bill 413 report that we submitted last year with where we talked through what the future of the reinsurance program look like and what potential affordability initiatives. So in that program, MIA, and we worked with them, estimated what would be the impact of losing the enhanced subsidies on both I think the reinsurance program and, average cost to consumers. And so we have that data from that report. And we have in our, each year when we do our reinsurance projections, we are modeling each scenario. What happens if the enhanced subsidies stay or go? And if they go, we are going to expect to see our federal funding drop. And yeah, that's going to trigger conversations with our board about what can we afford. So that is certainly something that will play a part. I don't think we haven't had those conversations yet. And, we won't know for a while, but it could certainly have an impact.
Yeah.
Allison?
Yes, good afternoon, everyone. Allison Mangiarchino with Kaiser Permanente. Thank you, Johanna, for this analysis and the preliminary findings. I think it's really helpful, especially given the uncertainty next year. Just wanted to express our support for that bullet discussing scenarios and just encouraging modeling to look at those various scenarios and how best to use those limited dollars to maximize enrollment, as well as continuity year to year. I think there's a good chance, we could be looking at changes in the APT structure, whether that's with the expiration of enhanced APTC or APT, how APTC is structured overall. So I think, again, important to look at what funding is available and how best to respond to those different scenarios. I think the young adult subsidy program has been extraordinary in its success, and we want to see that continue, but certainly have to consider changes overall in APTC.
Yeah, absolutely. No, that's a very good point. Well, I can hop into my next agenda item, but happy to come back to this, or please feel free to reach out to me over email if you have any questions or feedback on the young adult subsidy stuff. So the next item we wanted to discuss with the group was a proposed 2026 plan certification standard. Next slide. So just a refresher here, we set plan certification standards for plans sold through Maryland Health Connection, and those standards can touch on plan design, carrier plan operations, or other requirements that we think are relevant for consumers. So some examples are we required NCQA health equity accreditation of our carriers starting this year. The value plans that you're familiar with are plan certification standards that we started in 2020 and have been adjusting over the years. And, that's the requirement that each carrier offer a value plan at each of the main metal levels. And we have kind of assorted other plan certification standards. And each year we, think through, is there another standard? Are there any other standards that we think would be beneficial for our enrollees? and specifically, I should say the board sets these standards. So we as staff present them to the board and they choose to enact them or not. Next slide. So in addition to change, we have to make changes to the value plans every year to account for changes in service costs and stay within the metal level tiers that the federal government sets. So that aside, which we have a specific value plan work group that helps us think through those. Aside from that, the one proposed certification standard that we're contemplating for 2026 and welcome your feedback on is to require equivalent cost sharing for primary care and then mental health and substance use disorder office visits. So essentially, as background here, federal and state parity laws generally require that financial requirements like co-insurance or co-pays for mental health and substance use disorder benefits cannot be, the terminology is more restrictive than the predominant financial requirements that apply to substantially all medical and surgical benefits in a similar classification. So if you're looking at inpatient care, outpatient care, emergency care, you kind of bucket the care on the medical side and the mental health and substance use disorder side, and then you can't have a higher standard of more burden on the consumer financially for the mental health and substance use disorder benefits. And our plans sold through Maryland Health Connection and generally on or off exchange in the state have to comply with those parity laws, and MIA reviews carriers' plans to ensure that that's the case. But through kind of what I can kind of an oddity of the law, you can end up with a situation where because of how the services are bucketed, the cost sharing is compliant with parity, but it can be a higher cost to seek a mental health substance use disorder visit than a primary care visit. And that can be permissible under parity. It's not illegal, but it can be confusing to consumers who expect that those are sort of like primary care physically, primary care kind of for mental health should be on equal footing in terms of cost. And indeed, of the 5 insurers that operate on Maryland Health Connection, 3 do use identical cost sharing between these service types. So if you've got a $10 copay for a primary care office visit, you've got a $10 copay for your mental health substance use disorder office visits. And they do that, throughout all of their plans. It's just identical cost sharing across these buckets. We have 2 carriers that came to our attention through some outreach from consumer assistance workers who were confused and thought maybe there was something on non-compliance, that we had 2 carriers that don't have equivalency. And it's not that they're out of compliance, but as I said, just parity can operate and allow these differences in cost sharing. So we reached out to those 2 carriers to say, it would be great if you could follow suit and equalize or make equivalent cost sharing between these services. One has already responded and said, we're going to take that into account and do that in our 2026 plans. One, I'm not saying they at all were refusing to, but just kind of got back to us with we need to evaluate this and we're looking into it. So anyway, given the confusion that this has generated in the market and the fact that the majority of carriers are or are willing to do this, my hope is that it's a pretty non-controversial proposal. But so that would be the proposal for 2026, that there needs to be equivalent cost sharing between those service types. I will caveat with the technicality that due to the way parity works and this bucketing and comparison process, you can wind up with a situation where a carrier actually has to use, say, a copay on primary care and co-insurance on mental health and substance use disorder. If they're using, so I won't get into it, but it can end up that way. We would encourage carriers to use co-pays generally. We consistently hear from consumers and consumer assistance workers that co-pays are preferable because it's a defined amount that people can expect and know what they're going to pay versus a percentage of some mysterious amount with co-insurance. So we'd encourage co-pay, but I think we would go so far in this plan certification standard to require copay, because that could require a significant reworking of the cost sharing structure to the plan overall by the carrier. Within our value plans, they are equivalent and they do use copays, but for the 2 non-value plans at each metal level that the carriers offer, we give them discretion on how they structure their plan. So if there is a circumstance where they would have to use co-insurance on the mental health and substance use disorder, our plan standard would be that dollar amount of co-insurance must kind of on average be equivalent to what the copay amount is for the primary care. And so if primary care is pre-deductible, then mental health and substance use disorder should also be pre-deductible. So that's the explanation there, and welcome any feedback from the group now or kind of subsequently over email about this proposal. Joanne.
I'm like, whatever, I am 5 for 5. Sorry. This has been a great presentation. I have to say, I love this idea. I work on mental health parity enforcement and oversight, and it is so confusing for consumers to know how that math test on the substantially all and predominant that requirement that you mentioned would work out. And my family in using services has been told by a provider, it's a specialty visit, it should be charged this. And I say, nope, I know for my carrier, it's a substantially all and predominant, says it's the same as my primary, just make it clean. And there's so little that consumers can understand about what they're supposed to get out of parity that I think this would just really be immensely helpful to just say, and protect against some of, like providers saying, I think this is a specialty visit. It would just make enforcement, frankly, a lot easier, I think, or, that it would be very clear standard and make it easier for consumers to understand. And agree with the copay over co-insurance. I've had co-insurance applied to the wrong amount and paid more than I should. But again, because I study this stuff, I knew to ask. It's just, I really support this proposal.
Thank you. Stephanie.
I just wanted to second what Joanne said from the consumer perspective. This sounds great.
Thank you. Maya?
Yeah, overall, from a carrier perspective, I think we agree with this. I would caveat that just about the copay requirement. There are certain plan designs, such as HSAs and other types of plans that we try to offer in addition to the standard plans, the value plans, that might make sense to include a co-insurance value in certain circumstances.
Thank you. All right. Well, thank you for that feedback. Again, anyone else who has comments, please reach out to me. We would likely be taking this to our January board meeting to ask the board to approve that as a proposed standard. And then there would be a formal public comment period after that. But if you have any feedback that you want to send to me on this ahead of that, you are welcome to do so. And if you have thoughts on other plan certification standards that you would like the exchange to consider in the future, we always welcome that input as well. Great, thank you.
Great, thank you so much, Johanna. So I think, at the end of the 2024 year, our last SAC discussion, here's an opportunity for everyone to just, kind of list things that they might be interested in discussing in 2025. I know a lot of the things that we discussed last year in this meeting, ended up being on the agenda. So this definitely influences the agenda for the next year. So, are there any topics or issues you'd be interested in addressing next year, or other comments, questions, or suggestions on, on the operation of the SAC? I think you can just raise your hand and offer them. Amelia or Johanna, let me know if you want to add anything on this.
I would just add that a suggestion from last year was taking a deeper dive into mental health parity and what the exchange can influence in that realm. So to your point, yeah.
Great. Yeah, I think I might have endorsed that last year as well too. So and then today's discussion is too brought that up. So I would definitely be interested in a deeper discussion of mental health parity and the types of. I mean, today we discussed one sort of a quantitative treatment limit, but also thinking about how you think about non-quantitative treatment limits in plan certification or otherwise. I think would be of interest to me as well. Mary Teresa.
Okay, yes, and I want to take the time to appreciate, all this, being a part of this advisory committee. I know we've done some things, and often I've brought up issues relating to cancer care because that's my specialty. And I just wanted to leave you with this food for thought because right now, we as HOPA members, Hematology Oncology Pharmacy Association, we have been looking into this parity issue between IV chemotherapy versus oral chemotherapy. So, and I know, I mean, since this, council deals with payments and all that, I don't know how the message can be taken to the legislators in terms of having payments come from patients' insurance, equal payments, and not having one aspect of treatment coming through pharmacy benefits and the other coming through medical benefits. And because it doesn't help the cancer patients a lot, doesn't at all. Some of them have actually had relapse from not being able to get their oral medications. For those of you that are, you know anything about cancer drugs, they are very expensive. So right now, the oral chemotherapy has to go through pharmacy benefit. And the pharmacy and the copays are just 25% or whatever. No, I'm not just giving a scenario. The copay might be 25%, but when you look at 25% of a $3,000 or $5,000, pay amount, it's a lot for somebody to afford out of pocket. But the IV infusions are free. They are, they don't have copays. They are free through medical insurance. So I'm not sure that I'm bringing this, but if this is not the right place to bring this up, I just wanted people to think about it, and so maybe take it to the right, because that's what we've been fighting for now. Actually, 2 months ago, we were at the Hill visiting different legislators. I love to advocate, so I advocate for different groups, but specifically for cancer patients, and I know that I've mentioned in this group that I am actually a survivor myself, but I'm fortunate that my treatments have been infusions. So other than the initial, deductible that I pay, I don't pay anything else, so I'm just throwing that out there for food for thought. If anybody has any comments as to how this can be resolved. Yeah. Okay. Somebody's raising their hand. So I'm hoping that I get something. Okay,
Well, first of all, thank you for your advocacy. From Maryland Healthcare for All's perspective, we are advocating for Maryland's Prescription Drug Affordability Board to be able to have its authority expanded to set up our payment limits for all high-cost medications for all Marylanders. So I would love to talk with you offline if you are interested in that.
Yes, definitely. Okay, thank you.
And I will just say on a smaller scale through our value plan standards, I think our silver and gold value plans have a separate prescription maximum out of pocket so that even if you did have a if you did have to pay for, say, a high cost cancer drug, you're not going to have to be subjected to the full deductible and max out of pocket of your plan. So for those particular plans, we were trying to kind of shield people from really high prescription bills. That's a little slice of the population, but one aspect for us tackling kind of that general issue.
Yeah, and that helps, and I think part of the problem too is like educating the patients as well, because some people they don't go for the appointment because they just said they cannot afford it, so I'm not sure how we can help. There's so many issues in taking care of the cancer patients currently. I mean, on my end, I'm working very well at the school here with the students. We formed a professional student organization and working, with Encoder. So, but some of the problems that we're facing is the stigmatization of cancer in the community, which causes a barrier for patients to seek help. And then the payment issue is another, what we call financial toxicity, in terms of part of the financial toxicity in the care of the cancer patients. So, but I'll talk to Stephanie afterwards. But thank you so much, Joanna, for that information.
Joanne?
Actually, that reminded me, another sort of similar issue is continuous glucose monitors considered either DME or pharmacy, and to the extent you have value plans that try to prioritize cost sharing for diabetes, I'm wondering if it's worth a look. I don't remember actually if they do assign them one place or another, but with DME, it can be harder to access them, fewer places to obtain them, and also more likely to have co-insurance versus co-pays. So that might be something worth looking at to sort of complement the focus on more affordable access to diabetes care. And the other thing is just a request. I really do appreciate Michelle sort of outlining some of the issues already on your radar that might be changing and coming down the pike. And I would appreciate just, it is true that having a state-based marketplace insulates you from some things, and other events are just going to affect what you do no matter what. And I would have, I think in some cases you'll have to really be quick on your feet and respond, and we'll appreciate those updates as things roll out and you're thinking about how to deal with them. That's really helpful, and I appreciate the report at the top of the meeting in that regard.
Joanna, can I piggyback into what you just said? Thank you for bringing that up. My practice site right now is at the Wycomico Health Department, and I was speaking with the physician yesterday, and she mentioned the problem that she's having with, I don't understand why CGM is not available for all diabetic patients or suspected by diabetic patients, because part of the problem is the literacy problem with the patients. And the regulations for the CGMs are the person has to be on insulin. But I don't necessarily think that they should put those, those barriers to obtaining the CGM. And so if the person is not on insulin, they cannot get the CGM. And I'm wondering if something could be done within the state so that all the patients are able to, patients that are monitoring their blood sugar and everything, even though they may be on oral agents, but they will still need that CGM, especially if they are not literal enough to do those blood tests. I think we all agree, talking to the physician, we all agree that, it's easier for them to be able to monitor the blood glucose through, the CGM. And she sees a lot of patients that are already hypoglycemic. They will not know if they're not testing their blood. She said they just don't want to test, or maybe they are not equipped to test. So my concern is, or my suggestion would be to find a way to have, everybody that is diagnosed with diabetes to be able to have access to the CGMs in Maryland.
Thank you for that feedback on CGMs from both Joanne and Marie-Therese. That's something that we did look into when we initially launched our diabetes benefit through value plans, but I think it would be a good time to revisit it. When we looked at it a few years ago, there, from the folks we talked to, there wasn't a lot of literature at that point on the impact of CGM on kind of diabetic care. Although as someone who has type 1 diabetics in my family, I get personally lobbied regularly on what I'm doing to make them more accessible to people. So I do know from like a personal utilization standpoint, I understand the appeal and the ease of use. But you know, it's been a while since we looked into that, so I think it would be good for us to kind of revisit that issue, and we can certainly you know, investigate whether they're considered DME or covered under the medical benefit, and find out more about that.
Thank you.
I'd also like to put out there, I'd be interested in a presentation and a discussion of, you know, the small business program advisory committee. I think it's been a while maybe since there's been a presentation. I'd be interested to hear what they're thinking about, and I think especially with potential changes coming down the pike, I think with, you know, association health plans or whatever it is that, you know, that might be going on, I think at some point it'd be nice to have a discussion in 2025 about that as well. And Joanne, do I have a second from you? I saw some nodding, so.
That's a great idea. We'd love to do that. We've got a lot going on with our small business program, so that's a great idea to connect those dots.
Are there any other topics that anyone would like to bring up? Okay. Well, if not, I think we can pause to see if there's any public comment. Okay, I mean, hearing no public comment, I think, Amelia, Johanna, do you think makes sense to end early? Great. Well, I'd just like to say personal thank you to everyone. It's been great working with you all this year. I hope everyone has a happy holidays, and I look forward to seeing many of you in the new year. And I'm grateful for all of that I've worked with in the past year. So thank you all.
Thanks, everybody. Good to see you.
Thank you.
Thank you all. Bye.
Thanks, everyone.
Thank you. Bye.
Bye-bye.
Thank you. Happy holidays.